This podcast is for healthcare professionals only and is supported by an independent educational grant from Beatrice.
Good morning. My name is Dimitrios Tsakiris and I'm a hematologist at the University of Basel in Switzerland, specialized in hemostasis. We would like to discuss with you today the issue of monitoring anticoagulants. We think that this is an important topic because it helps practitioners of medicine to judge intensity of anticoagulation and under certain circumstances also help them guide treatment of these patients. But first, let me welcome Professor Michael Nagler in the discussion. He is an expert in laboratory medicine, a hematologist, epidemiologist, and I would like to let him introduce himself in the discussion. Dr. Nagler, please.
Thank you very much, Dimitrios. I'm happy to do this with you. So I'm really interested in the topic of anticoagulation in monitoring, and one could even say that this issue significantly influenced the course of my career. So the key question I was always interested in is, what does this specific test result or lab test result mean for the individual patient? And I'm very happy to discuss that with you, Dimitrios.
Thank you, Michael. We would like to start with some technical aspects because understanding the technical background of the test systems is crucial for the choice of the monitoring way, how to go. Now, we know that anticoagulation is available since almost 60 years now, and there have been traditional test systems to follow them, at least the first anticoagulants that were available. But since 10 years now, we have a variety of new direct anticoagulants which help us treat patients, but they pose a technical problem concerning measuring intensity of the action of these drugs. We will focus on the direct oral anticoagulants first because they are widely used nowadays. And we know that there are some techniques which vary between themselves available to monitor them. The gold standard, for example, when DOACs were introduced in the treatment was mass spectrometry. This is a very elaborate technique which is not available in the usual laboratories, but on the way, simpler test systems were developed which were specific or more universal for detection of these drugs. So could you introduce us a little bit to these techniques, Dr. Nagler? How did you experience the appearance of these specific or universal anti-10A test systems, as they are called, for monitoring DOACs?
Of course. So I fully agree that mass spectrometric methods have clear advantages that qualify them as the reference standard. Sensitivity in very low concentration, specificity in terms of which drug is used, capture of drug metabolites, linearity, also in low and high concentration. But yeah, you already said this, they're not available in clinical practice. Results need to be available quickly, and this is simply not possible with mass spectrometric methods. These chromogenic anti-10A assays that capture the inhibition of exogenous factor 10A, which we have known for decades from heparins, can be implemented on almost any coagulamator, so it's at least in theory widely available or can be made widely available. So these techniques are good and we're experienced in it, and when we adapt it accordingly to the direct oral anticoagulants and implement it in current healthcare processes, I think they can be really of value.
You know, in medicine, making things simpler is always very attractive. And there have been visions followed. I can think of that Theranos issue where out of one droplet of blood, you could check any kind of test analysis that you would like to, but that was illusionary at the end. Now, if we think of that development in the anti-10A assays, that a universal anti-10A test system could be sufficient to be used for all three available DOACs, that would have a great impact in practice in medicine. Do you have an opinion on that? Because there are some studies, very interesting studies, which confirm the usefulness of such a test system.
Absolutely, I fully agree. The problem of these anti-10A assays are practical nature, though you normally need one calibration for every drug you would like to measure. And there are quite a number of ideas and tests and studies to apply a universal calibrator to this. And we did a very large study, used different calibrators, tried it out with different calibrators, and it works if you concentrate on categorical critical drug levels. And then it works very well. But if you would like to measure accurate drug levels, I think it's hard to implement it, unless there will be somewhere in international WHO standard or something. But if you would like to measure specific drug levels in terms of microgram per liter or something, I think a universal calibration is not possible. But if you go for categorical values, clinical relevant drug levels, I'm convinced it works very well. And this is the thing which is important, the question which is important for the physician.
Yes, that is correct. But we have to think here that manufacturers have published actually, at least two of them, only anti-10A universal values of the activity of the drug. So we have an option to judge how much intensity do we have in circulating blood concerning the drug. And as you said, this should be a categorical evaluation and help the clinician say, I have enough or not enough or too much of that. Would that help a little bit the implementation of this universal test?
The questions physicians would like to ask and the decisions that they have to make is, shall I give an reversal agent in case of bleeding, or can I operate this patient safely in case of urgent surgery, for example? And for this, these are, clear clinical questions, and they can be answered in a categorical way, yes or no. Are the drug levels low enough that I can go straight forward to operation, for example? And so in this way, it's possible, easily possible with categorical cutoff values. You don't need, for answering these questions, you don't need a precise information on the drug level.
Correct. I mean, at the bedside level, this is correct. And now you have noticed we have already bridged the way to the second main topic of the discussion, the usefulness of monitoring the anticoagulants. And this is important to discuss because traditionally anticoagulants, at least the first ones, have been very closely followed and monitored. But since the appearance of the newer direct anticoagulants, we don't need that. At least the manufacturers planned and offered us studies which showed that close monitoring is redundant. But despite that, I know that in laboratory medicine, two philosophies exist. One says we don't find anything if we don't look for it. And the other says a non-investigated patient is a healthy patient. So you have to choose what to follow. Personally, I prefer the first option to measure everything that we can measure, because that helps us understand the background of any medical problem. But concerning these statement of the manufacturers that we don't need monitoring of the dose, how do you experience it in everyday life? I mean, if you have a very well established anticoagulation in the patient, you don't need to know how intense it is. It works. But what do we do in case of emergencies, emergency operations, or bleeding? How do you experience that in your everyday work?
So I believe we have to distinguish two distinct situations. First, monitoring in the narrow sense, and the detection of critical drug levels in the context of acute bleeding, upcoming surgery, and thrombolysis. In the second case, there are many experts who see a benefit of measuring drug levels. Yeah, I mean, for a decision of whether I shall give a reversal agent, whether I can proceed to surgery, whether I can proceed to thrombolysis. In the case of monitoring, in terms of determination of peak or trough level concentrations and adjustment of the drug dosage, I mean, there are no studies that demonstrate efficacy and safety of this type of management. I mean, I have to know what to do. Yeah, when I would find a lower than average drug level in some patients, shall I increase the dosage? Or if I find higher drug levels, shall I lower the dosage? There are simply no studies which study this kind of management. And also, I mean, the dosage of the drugs, of the tablets, is more or less fixed. So this is an important aspect of monitoring, or important piece of evidence that we need before monitoring. We must know what to do, and this management must be confirmed and studied, and this is simply not available. So I think it's a strong argument against monitoring in routine clinical practice. But of course, we are measuring drug levels in special situations in many diseases and many patients. And it's important to know the drug levels before surgery. And so I think many experts agree on this, also extrapolated from other diseases and other situations. So I think we have to distinguish two situations. And I believe it's useful in a number of special situations, but monitoring in terms of adjusting the drug levels in routine clinical practice, we simply do not have the data.
That is correct. I mean, the variability of the kinetics of these drugs do not need to be checked and adapted according to the intensity or concentration, because they work. It was what studies showed us, the license studies of all of them.
In the last 10 years or so, quite a number of observational studies appeared in special patient groups. I mean, very obese patients with renal, at least moderate renal insufficiency, old patients, and so on. And the essential results are or the interpretation is it works in every patient group. So we do not see a particular patient group where the effectiveness, efficacy, safety differs dramatically from overall. Also, I think a strong argument against a routine monitoring approach.
That is correct. But you think that we still need them in special cases, such as you mentioned, stroke and fibrinolysis treatment. Do we have circulating drug or not? That would be a no-go. Or indication to give a direct antidote. Do we have circulating drug or not? I mean, measuring that under these circumstances is possible because automatization allows us to have a result in short term. You don't have to wait hours for that, but just minutes today. So if I would like to close that first part of the discussion before we go to the next topic, I could say that a key message would be in this situation, choose wisely whether you would like to measure drug intensity, but keep in mind that you don't find anything if you don't look for it. So in special situations, it is useful and can be usable, quasi, the result of the testing of anticoagulation. Now, just a few words to change the subject a little bit and go back in time to the older anticoagulants. It is undisputable that vitamin K antagonists need monitoring, as it has been done until now with INR following, and heparins need also monitoring, especially unfractionated heparin. There is a trend lately to follow unfractionated heparin with more modern anti-Xa tests. Many big hospitals in Switzerland have already implemented that. Do you have an opinion on this? Should we leave traditional global tests such as APTT back and take the newer anti-Xa test for unfractionated heparin?
Yeah, also the efficacy of unfractionated heparin, but also vitamin K antagonist depends on so many patient factors. And we have been used to monitoring for decades. With regard to unfractionated heparin, guidelines still recommend the APTT for monitoring, but mostly for theoretical reasons, and they consider it as a functional test. But everyone in clinical practice knows the problems of the many influencing factors, and the clinical data, and I reviewed them recently, the clinical data supporting this evidence were collected decades ago, and these are simply poor. So I'm convinced that the observational data we have for anti-Xa measurement are much better than APTT. So there are observational studies, very old observational studies supporting APTT, but I'm convinced that the data we accumulated with regard to anti-Xa to date are better than for the APTT. And I think it's still recommended for theoretical reasons. And the arguments are, in terms of clinical data, are not good. And every institution I know which implemented an anti-Xa approach is very happy with it.
I would agree with that. Anti-Xa test systems can be more standardized in that way, which was not the case with the classical global anticoagulation assays before that. So I think we have come to the end of this discussion. Please allow me to summarize very briefly and give you three key messages as we have discussed them, focusing on DOAC. DOAC monitoring is useful whenever we need it and whenever we need to know the activity of circulating drug in special situations, but not as a routine monitoring. DOAC choice and dosing should still be guided by individual clinical characteristics that we should keep in mind and not let us guide by the monitoring results. And labs can still efficiently use their traditional test systems to monitor anticoagulants, but in the name of the better interlaboratory comparability, anti-10A assays should be preferred over other. Dr. Nagler, before we close, do you have an additional point to give us?
Thank you very much. There's an additional point. I have a strong opinion, and this is the monitoring of vitamin K antagonists, because there are still patients treated with vitamin K antagonists, and the monitoring of these patients is rather difficult, and you need a lot of training and practice to do this, and doctors are not used to it anymore. So if you have patients like this, I strongly recommend to send these patients to designated training programs or monitoring programs. For example, patients have monitoring or other anticoagulation clinics, because this is a difficult treatment and needs a lot of practice. Thank you very much for inviting me, Dimitrios. It was a pleasure.
Thank you, Michael, for that. Thank you, listeners, for being with us today. We hope that you will enjoy this topic. See you and hear you next time. Thank you.
If you enjoyed this podcast and want to find out more, then please look for the Hematology Medical Conversation podcast under the account of Core2Ed Medical Education. Also, don't forget to rate this podcast, subscribe to our channel, and share it with your colleagues. Thank you for listening, and see you next time. This podcast is an initiative of Core2Ed and developed by Hemostasis Connect, a group of international experts working in the field of hemostasis. The views expressed are the personal opinions of the experts, and they do not necessarily represent the views of the experts' organizations or the rest of the Hemostasis Connect group. For expert disclosures on any conflict of interest, please visit the Core2Ed website.